All right, hey guys. So this is a repeat lecture from beginning of last year, but I know a lot of the first years were requesting it, and then I know some of the second years wanted me to go over it again. So it's basically an intro to venous congestion. It can obviously go into a lot more complexity, and then the fun part about doing all this is obviously hands-on training, which we will try and get either in person or at a small focus section at some point in the next few weeks. Um, so I obviously can't see anyone in the classroom, but how many of you guys have any experience assessing people for volume responsiveness or for volume tolerance? And so the reason I asked the question about volume responsiveness versus volume tolerance is that they're very different questions. In one question you're asking is, can someone does someone respond to having more fluid? And I think that's a very poor question to ask because anyone is going to have some sort of response to fluid. You know, you may have a person whose blood pressure may improve by giving fluids. You may also have someone whose blood pressure may get worse by giving fluids by increasing that preload in a weak heart. And I think a better question to ask is a person tolerant of volume? How can we assess for volume tolerance? And what I mean by volume tolerance is that you have to consider fluids like any other drug. In essence, volume in the form of like LR or whatever isotonic, colloid, or crystalloid infusion that you give, it is a drug that you are giving, and the effects of that can be detrimental. And so, you know, when we talk about patients, you know, that you have someone that's hypotensive or someone that you're concerned about impaired perfusion, and someone that is in shock, you're asking that question, is there any evidence of venous congestion? And, uh, you know, bringing into call a popular protocol that I think is going to play a big role, if not already, in how we assess patients or how we resuscitate patients um, using the VEXUS protocol or venous congestion in ultrasound. Um, Things that have really popularized in the last couple of years by you know, some of the ultrasound gurus who I'll mention. So, you know, what I want to do is I want to start off with a case. So you get a rapid response for a gentleman who's in his 70s, has a low blood pressure, heart rate is in the 110s, respiratory rate is in the 20s. He was initially admitted for sepsis and, you know, possible bacteremia. Like most patients that you suspect, he got, you know, your early goal directed therapy. So your 30 cc per kg fluid bolus along with empiric antibiotics. You know, you talk to the patient has been hypotensive, they're feeling lightheaded. You know, you on your way to the rapid response, you quickly view your labs and you see that the patient has elevated liver chemistry test, meaning their ALT, AST is elevated, they have an AKI. How are you guys beginning to assess this patient? Anyone here? Sanjay, you set it up, so I know you're in the room.
Yeah, I'm sorry. So you showed that the guy was hypotensive, and I'm sorry, I missed the second part of that right there. What you were saying?
He's hypertensive. He's feeling dizzy. You're concerned he's lightheaded. You're concerned about you know, the blood pressure. How are you initially assessing the patient?
Assess his mental status. I mean, his vitals are low at this time, so that's my most, or his BP is low at this time, at that time, so it's my most concerning thing. Want to stabilize the patient, get some collateral information from the nurse, and probably start him on some fluids for the time being until buy myself some time to figure out what's going on. If you have the ultrasound there, which is I know the point of this lecture, you could, I mean, start a point of care ultrasound exam.
Okay, so we'll get to that in a second, right? So I mean, a few things, right? This is your classic rapid response call. You have someone that is a rapid response was called for low blood pressure. You initially evaluate the patient. You know, I think things that you're initially assessing in your exam is, like you said, mental status. I think it's very important to assess, is the patient encephalopathic? Because what are you trying to determine if that patient is in fact encephalopathic when they were not before? It may be due to the fact that they are having impaired perfusion to their brain that's causing their encephalopathy. That's why altered mental status is a sign of being in shock. The other things that you can assess for is capillary refill. Is it delayed? Are their extremities cool? These are all signs of what could be pointing to impaired organ perfusion. And then you have some more ancillary evidence in the form of elevated liver chemistry tests and an AKI that yes, in fact, this patient might be having impaired organ perfusion. For those of you that thought maybe let me check out the stethoscope, let me bring out my stethoscope to try and listen to the lungs, see if they're congested. I personally think that will cause a delay in diagnosis. As you can tell, a lot of the fellows no longer carry around a stethoscope. There's no evidence that it improves care. And honestly, I think it's just an old device that doesn't have much role. In acutely resuscitating a patient, and truly believe that it's just going to delay your time to diagnosis and delay your time to resuscitation. And so, I completely agree with you. I think an ultrasound is very key here. If you guys have had the chance to be rounding with me or be on rapids with me, then you know that no matter who the patient is or what the rapid response is for, that I want you to bring the ultrasound into the room. And likely the only time you will not use the ultrasound is if the rapid response is in fact a fake call. So you mentioned using ultrasound device. What are you using the ultrasound device? What are you trying to assess when you put the probe on the patient, besides ensuring that you get IV access?
Yeah, determine potential causes for the low blood pressure. So if he's having like minimal contractility in his heart, is it cardiogenic shock? Is he having, RV collapse suggestive of like a PE? You could look for venous congestion in the liver. There's a lot of different things you can use it to help determine the etiology of the hypotension.
Yeah, absolutely. And I think when you have someone this ill, what I would recommend is foregoing the heart exam altogether. Yes, you will eventually look at the heart. Yes, you should do your due diligence and see if there is edema in the lungs, if there is a pericardial effusion around the heart. Does the heart have good contractility? Yes, you will likely eventually measure a cardiac output and see is the patient in possibly cardiogenic shock. But I think your initial step there was that, what, the patient is hypotensive, let me give fluids. And I think that is where we kind of run into mistake number one, is that like we talked about, the theme of this lecture is that fluids are a drug, and that the safe answer is not always to give more fluid, because what might be in fact happening is that the reason the patient is hypotensive is the severity of the fluids given, and likely that excessive preload is impairing your cardiac output. And so we talk about, venous congestion. And so like you have to think about how fluid plays a bad, plays a detrimental role in the body's pulmonary physiology, right? So we think like, just starting off with like, everyone thinks about like tissue ischemia from impaired output. We don't think about much about ischemic injury from congestion. And so start at the heart, right? Your right ventricle and left ventricle interaction is like markedly influenced by fluid management. Um, Imagine if you give an excessive amount of fluids, what ends up happening is that you take that septum of your RV and then you push it towards your LV, further impairing your cardiac output. You're decreasing the compliance of the left ventricle because of that increased RV wall tension. And then you just further, by adding more fluids, you're further causing deterioration of the patient. Whereas in this case, if you're able to successfully volume reduce the patient, reduce that flow from the right ventricle and decompress the right ventricle, you improve your RV function, you improve filling of the left ventricle, you improve compliance of the left ventricle, thereby improving coronary perfusion. Then you're also helping to get rid of congestive damage from the backflow from the RV into the venous system, into the liver, and basically like damage from congestive hepatopathy. Think about like tamponading your glomerulus by excessive fluid. You're drowning your kidneys in fluid, and kind of causing that early cardiorenal type 1 syndrome. And overall, going back forward, you are increasing cardiac output. So by looking at congestion, you can help better differentiate the cause of organ injury. So again, there's two types of liver damage. You can have ischemic hepatitis, or you can have congestive hepatitis. Same with the kidneys. You can have ischemic AKI from not getting enough blood flow to the kidney, or you can have congestive nephropathy from basically drowning your kidney interstitium or intracapsules and glomeruli in an excessive amounts of fluid, causing the AKI. And even in this, can go forward backwards. What goes behind that is the intestines, right? You can cause traumatic volume overload and cause interstitial edema or gut edema, and that's why like your oral meds will no longer work. And then finally, on the left side of the heart, when it gets bad enough, you'll also cause fluid retention in the lungs, causing that pulmonary edema. But Yeah, this is kind of just showing that same diagram. It's just showing that in patients that are volume overloaded, what's exactly happening at a physiological level. In the same way that can get ischemic damage from not getting enough fluid, you can get ischemic damage from too much fluid. Um, and we probably, a lot of you guys will look at B lines and decide, maybe if the patient has excessive B lines, maybe then I cannot give excessive fluid. Just remember that in order for the in this type of acute setting where someone came in for sepsis and you gave excessive amount of fluids and now you have B lines, that's a very late finding. You had to cause the damage to the right ventricle. That right ventricle had to decrease your compliance with the left ventricle by pushing that septum, and then the left ventricle had to start failing and build up fluid in the lungs. On top of that, there may be a comorbid condition that can cause B lines to already be in place, so it may not be reliable. If you guys remember from the lung ultrasound lecture, there's only one thing that the presence of B lines tells you. Does anyone remember what that is? Because it's not that there's fluid in the lungs. The answer is that there's no pneumothorax. That's the only thing that B lines tells you. So knowing that, it might not be the most reliable marker of not to give more fluids. Regardless, in someone like this who's lung ultrasound, I'm seeing this, I'm likely very, very hesitant to give fluids. Quick question for the people in the classroom. Are you guys able to see the ultrasound images moving?
We can't see anything moving.
Yeah, we can see it moving. Or at least on mine, I can see it moving.
I can't see it.
Oh, well, all right. Well, anyways, there's a bunch of B lines that are moving here. And then so on this image, what I'm seeing is, I want you guys to take a look at this. And these are two cases, one is A, one is B, of what could be going on with the patient. So I recommend that your first scan in this patient should be the IVC, because that'll clue you into where to go next. And so you measure out the IVC in both instances, and you see that on the top one, there is evidence of a plethoric IVC with minimal respiratory variation that measures about 3.4 centimeters. And for those of you guys that don't have experience measuring the IVC, you want to look at it in two axes, and you want to make sure you scan. So if your IVC is like this, you want to make sure that you scan all the way up and down. So that way you make sure you get your maximum diameter. And same if your IVC is like this, that when you scan and you get your view like this, you're going all the way up and down to make sure that your IVC, you're getting your max diameter. Because remember, it looks like this. So if you scan from up here, it's going to be a much shorter diameter than if you scan from here. Is anyone able to see that okay? So you want to get your max diameter, then just press the freeze button, and then you can take the mouse pad and scroll it to get your largest diameter, and then you measure that. And so the top one is 3.4 centimeters. You see that on the video, it's not moving, versus the bottom one is 1.8 centimeters, also very plethoric with minimal respiratory variation. Now, the common teaching, at least what most people learned in med school or early on when they were.
Sorry to interrupt. We can't see what you were saying for the past like 2 minutes. There's nothing on the screen.
Are you guys able to see the screen right now or no?
That might be a Vibe specific issue because I can see both the images and the screen, like everything is there on mine.
I can't see anything.
Yeah, neither can we here.
Do you guys want to quickly just try hanging up and joining the call again?
I
I'm
tried.
Sure.
I'm looking at it on my phone. It is working.
I just tried that Uday and it still didn't work for me.
How about now?
Nope.
In the classroom? Stanley and Nawab, it's working for you guys?
It's working for me.
Yeah, I can see everything.
All right, cool. Yeah, there's not much else I can change on my end. Maybe Joanna and Vibe, if you guys are having issues, just join from your phone, because it should be working.
It's actually working on my phone, so I switched to my phone.
Might be the computer then. All right, so where we were. So, basically you have two cases here where there's evidence of a plethoric IVC, one diameter is larger than the other. And so the common teaching is that you can correlate the IVC diameter plus or minus respiratory variation with your CVP. And those studies were initially done, in the idea to say like, okay, if I have a patient who's on who I'm ultrasounding and I have a Swan Ganz catheter in them, that I can correlate the CVP pressures. And the idea is that, you know, you are getting pressure from your right heart into your IVC that's now going already into your CVP, and then that's going backwards. And that diameter and respiratory variation down your IVC can correlate with this. Now, keep in mind that there are certain caveats to this that I think we tend to forget. When you think about how you get your CVP, remember that it is a sum of the pressure in your inferior vena cava plus the sum of the pressures in your intra-abdominal pressures. So once your IVC is descended, any change in size is going to be due to acute changes in your intrathoracic pressures or your intra-abdominal pressures. So that's only if your IVC is distended. Meaning that if I take a big breath, right, and I decrease my intrathoracic pressure, I am going to decrease my intrathoracic pressure and tell volume to come back into the thoracic space. And so you're going to expect to see your IVC to collapse. Even at really high central venous pressures, you're still going to see that collapse because you're going, and you're going to see that fluid go back in. And that's, how you get your like respiratory variations. And the reason that's important is because there are certain caveats to this. So the caveats kind of really are learned from what the evidence shows. I know this slide might be hard to see, but I'll read through it. There's a few papers that discuss like, what we call collapsibility index. How well can that IVC collapse with respiratory variation? So as you increase your CVP, you expect to see more venous return, and you expect more of that tendency to collapse go away because there's more pressure in your CVP, meaning that with that respiratory variation, you're not going to see that collapse as much. And so since we're saying that in this case, your change in your IVC is related to your change in your CVP, there might be a direct relationship. But when you actually look at the data, in a spontaneously breathing patient, that the IVC collapsibility, meaning the change in respiratory variation, has not been found to be predictive of your central venous pressures nor of fluid responsiveness. And that's for a few reasons. One is that you don't know how much variation there is amongst people in terms of their inspiratory effort. For example, a healthier person might be able to, with good lung compliance, might be able to have a much more dramatic change into thoracic pressures that would cause a change in your IVC. Someone who has maybe cirrhosis or has a lot of ascites, or has a bowel issue, or is even something as simple as constipated, is going to have much larger intra-abdominal pressures that's going to be compressing on the IVC. And despite how healthy they are and how much of a change in their intrathoracic pressures they're able to produce, they're not going to get much of a change in their intravenous pressures because of complete compressibility from that increased intra-abdominal pressures. So then the whole idea that, if you guys learned, it's great for a board question, but it's just not in clinical practice very accurate for estimating CVP. So that whole table of like, less than 2 centimeters with greater than 50% variation is indicative of a RA pressure of 3 versus greater than 2 with no respiratory variation is about 10 to 15 versus anywhere in between is about 8 to 10. That really doesn't apply. The other thing to keep in mind is that all of that is reversed for a patient that is mechanically ventilated. So what happens in a mechanically ventilated patient? The question you should be asking is whether the patient has IVC collapsibility. The question you should be asking is whether the patient has IVC distensibility, meaning that when you take a breath, meaning the machine applies a breath, the ventilator applies a breath to the patient, you are increasing your intrathoracic pressures. And by increasing your CVP, you are increasing your IVC diameter. So it's the exact opposite the other way around, that instead of the IVC collapsing with inspiration, you're getting IVC distension with an inspiration, with an inspiratory breath. And also that is, again, affected by your baseline IVC at your baseline IVC pressures, which could be affected by venous congestion. So if you have someone that's very, very congested, you're not going to get that much desensibility in someone that's mechanically ventilated. And again, you see that in the trials, that when applying positive pressure breaths, IVC desensibility did not correlate with a good CVP when you put a Swan-Ganz catheter in. So what does that mean? And so, we talked about a few other caveats of when just using that IVC by itself in isolation does not work. In someone who has, say, chronic pulmonary hypertension or chronic RV failure, they are at baseline going to have a lot of IVC congestion. And what happens with that chronic IVC congestion, just like how you get heart remodeling from fluid overload, or like how you see people with chronic heart failure or lymphedema, how their legs, their veins just look different. Their veins aren't able to get that good strength to drive all that blood back to the rest of the body. You'll start to see that in the IVC. And then you will at baseline see a larger IVC diameter without changes in their size as the CVP changes. Because remember, your heart is here, it has to just fighting gravity. A patient is upright at baseline, has to go up and then down. So most of the damage from chronic venous congestion is going to happen on the downslope, not on the upslope. So, even just at lower central venous pressures, you're going to have an IVC that's already dilated. You're not going to tend to see the change, and that there's pretty good evidence for. So how can we better assess venous congestion if we are saying that the IVC in isolation is not good enough? So, in this question, you're saying that, okay, pretend you have that rapid response, you go and assess, and, you have two rapid responses of the same thing. One is A, one is B. In who are you going to give more fluids? In who do you feel comfortable giving more fluids in this hypotensive patient? And so the way to answer that question, sorry, Vibe one, go ahead.
B. Patient B.
Yeah, so you are saying that you want to go ahead and give fluids to patient in B. I'm guessing because of their IVC diameter is smaller, is that correct?
That seems to be the consensus.
Okay, all right, so let's go and find out what happened with this patient. So, what we wanted, we'll go ahead and come back to the answer. So what you want to do is you want to better go ahead and grade that venous congestion. You are concerned that because in both these patients, there is a large, in one of them, there's a larger IVC diameter with minimal respiratory variation. You want to go ahead and grade that congestion. And we are making it clear that the IVC is not good enough to do that. What you want to see is the effect of congestion. What if I said that through ultrasound, you could go ahead and measure the total effect of the congestion on your organ tissues, and therefore estimate that backwards transmission of that water pressure from the CVP to the organs. And what you're really looking at, basically measuring this, what you're looking at is pulsatility of the veins in your hepatic vein, your portal vein, and if it's the congestion is severe enough, your renal veins. And so, I would recommend reading this blog post on CV Physiology. It's a nice blog. And what they're basically saying is that when you think about the artery versus the vein, the artery does, arteries, and especially the aorta, you have a heart that's pumping out blood and able to dismiss it to the aorta. The aorta can kind of like bug down that pulsatility pressure by the heart because it's able to have a lot of resistance, right? It's a thick-walled artery with a very strong muscle around it. And as you go into your arterioles and capillaries, you can see that the resistance increases. As that resistance increases, when you are, have you guys ever had a patient where you've had an A line in both the radial wrist and the femoral? And ever compared the two? You'll always notice that your pulsatility, meaning your high systolic and your low diastolic, there's a much wider pulse pressure via the femoral line than via the wrist, because there's a lot more resistance in the catheter in your wrist than there is in the femoral. And that femoral is likely a much more true pressure of perfusion in the arteries than it is in the wrist. And so, it's got that elasticity to it with a high amount of resistance. So you are able to see that high amount of pressure. What happens when you enter the veins? That pulsatility goes away, right? In the veins, you see that here the issue is not so much, the capillaries in your capillaries, so your arteries, veins, arteries, capillaries, veins, arteries, little resistance, capillaries, high resistance. Veins, the issue here is compliance. Because retrograde flow from the right atrium going into the venous system, that compliance should really cushion all that pulsatility. So, when you are doing a peripheral IV, which everyone in the room should be good at, one of the ways that you check to see whether you are looking at a vein or a artery is to see pulsatility, right? You should see pulsatility in an artery, but you shouldn't see it in a vein. What happens when in a fluid overloaded patient, you tamponade the area, so you put the wrap around there, around the arm, you can actually start to see pulsatility in the vein. And so you have to be careful about that. And so with the same token, if you have severe congestion, that backwards flow from the heart into the venous system can actually cause pulsatility. And by that idea itself, because your compliance has been dissipated, the ability for the venous compliance for it to go, blow up with high pressures and get rid of that pulsatility goes away because there's just too much fluid in there. You can start to see pulsatility from the heartbeats going backwards in the venous system. And the more congestion you have, the further back into the congestion system you get to see that pulsatility. So it goes all the way from your CVP, into your superior vena cava, to your inferior vena cava, to your hepatic vein, to your portal vein, to your renal veins. And that's what the VEXUS scan does. Another good blog post where you guys kind of understand this, if all this doesn't make sense, what I've said so far in terms of like variations in pulsatility pressures. All right, so what I want you to take a look at is how do we do this exam? So the first step is that if you see that your IVC is distended, you go ahead and you start to look at your hepatic vein. So it's those branches of veins that are coming off in your liver going into the IVC. A way you can confirm that you are in fact looking at the hepatic vein. If you guys remember the mnemonic, BART, blue is away, red is towards, you should see blue colored Doppler, not to symbolize the vein, but the fact that it's going away from the probe into the IVC, basically blood flow from the hepatic vein into your IVC. If you are seeing red colored flow, meaning it goes blue, red, that tells you that there's congestion so bad that when the heart is beating, as the atrium contracts, blood also goes backwards because there's so much fluid into your superior vena cava, into your inferior vena cava, and then backwards into your hepatic vein. So instead of going into the IVC, it's leaving the IVC and going back into the liver. And so you can imagine that the liver cells are drowning in fluid with every other heartbeat. Instead of what it's doing, what it's supposed to, which is supposed to be sending fluid from the liver into the IVC towards the heart. So if you guys remember, like, when you put a swan in and you get those CVP measurements, you get like the A wave, the C wave, the X wave, all those can be seen in a backwards flow in the IVC. And I'll go through each one. And so the letters you have to remember are A, S, V, and D. And really the ones that you care about are the S and the D. So you put your pulse wave Dopplers, you press the D button on our ultrasound machines, and you line those markers up into your hepatic vein. And the neat thing about this, unlike traditional ultrasound Doppler exams, it doesn't matter in what axis you're in. It doesn't matter how far or away it is from the probe, because it's not based on angular velocity like it is with other ultrasound exams, especially all your cardiac exams. So it's a lot easier to perform than your cardiac measurements. And what you should see in a normal patient is that with atrial contractions, you should see backwards flow into your hepatic vein when that atrium contracts. That's normal. And the color flow should be going away from the probe, and that's what that S wave is. So it should be going towards the heart, right? So as your tricuspid valve opens up, your atrium contracts, blood flow should enter in diastole, should go from the atrium into the heart, into the ventricle. And you'll see a backwards flow because you're decreasing your into your right atrial pressures. So as you decrease your right atrial pressures, blood flow should follow a pressure gradient and go this way. And if blood flow is going this way, then you should see blood flow going away from the probe into the liver, from the liver into the IVC back towards the heart. And so that's why you see that negative deflection where you see the arrow pointing S wave. The D wave is more in diastole, and what's happening there is that blood pressure is now basically moving into the ventricle, and sorry, I mixed that up. So S is systole. So as systole, when your blood contracts, it's going to create that negative intrathoracic pressure, and that's what blood flow is going to go one way. In diastole, it's blood flow going from the atrium into the ventricle, creating that negative pressure in the atrium, and blood flow goes this way. Your A and your V waves are basically when you have the opposite. You should get a little bit of opposite flow. So when the atrium starts to contract, you should see as the atrium contracts a little bit of backwards flow, and then as it contracts and pushes all that fluid in the atrium down, then you get your S. Then when you have when you have the rest of the flow, you should see a little bit of backwards contraction when that tricuspid valve closes, and you'll see a little bit of a blip, but it's never severe enough, so it may be negative too. Your A wave will always be positive. And so what happens in severe congestion? In severe congestion, when that systolic flow happens and you have severe congestion, instead of the S wave being a negative deflection, it'll be a positive deflection, because instead of blood flow going away from the probe, it's going towards the probe, meaning from the heart into the IVC to the hepatic vein in severe congestion. And so this normal pattern of that, where it's like the red is negative and the green is also negative, it'll be reversed. Sometimes it can be hard to differentiate which one is your S wave and your D wave. And this is one of the caveats to looking at the hepatic vein. I don't know if I can zoom in, but if you guys are able to kind of see this image on the bottom left a little closer with the Doppler flow, it's hard to tell which one is your S and which one is your D. The only way to know for sure is to connect EKG leads, which you can with our machines, to the patient and see when the atrium is contracting, when the QRS is. And that S wave is going to be right after the QRS. So as you get your systolic contraction, meaning right after the QRS, that is your S wave. And you want to compare that to the falling wave after that. So there are some caveats to this. You may not be able to see the S wave if you have, you may not be able to see the A waves, meaning that atrial contraction. A common scenario where you won't see the A waves is if you're in AFib. So because it's going like this, you won't see that A wave. You'll just see little blips. You may not see it in someone who's got chronic pulmonary hypertension. So in someone with like really bad systolic right ventricular dysfunction, like cor pulmonale, that S wave chronically, because there's remodeling of that right heart, is going to cause backwards flow. So even at baseline, you will first see backwards flow, and then you'll see your S wave. And that's a bit more complex. You'll only see it in really bad patients with pulmonary hypertension. And then in really severe tricuspid regurgitation, which you can also assess with Doppler, you'll always see S flow reversal, meaning that in systole, you'll always get backwards flow, because with every systolic contraction, that tricuspid valve is open because of regurg, and it's going backwards. And so in a normal patient without chronic remodeling, in a normal patient without tricuspid regurg, in a normal patient without AFib, your hepatic vein is a surrogate for your central venous pressure waveforms. It's pretty much the same venous waveforms, just you're looking at different things. And in what's happening here, once again, is that the hepatic vein is not dissipating that capillary resistance. And so all that compliance ability to cushion is gone. And that's why you start to see pulsatility. Remember, in the vein, you really shouldn't see pulsatility. So normally, your S wave should be greater than your D wave, because normally your systolic backwards flow is going to, the flow, when you get systole, you create that negative pressure, blood will go this way, is going to be a lot stronger than when you get at end diastole. However, in severe congestion, that systolic flow, because there's so much with that systolic contraction, more blood is going to go backwards, and then you start to see that the S wave becomes smaller than the D wave. That's grade 1, or it will combine with the D wave. That's grade 1. The S wave will be smaller than the D wave. That's grade 2. And finally, the S wave will be going the negative, the other direction, which is grade 3. And sometimes you don't even have to put the Doppler waveform. You can just put color. And if you see blue and red, you already know you're grade 3. So that's the hepatic vein. Now let's go further back. You go from, venous blood goes from the intestines into the portal vein, into the liver, and then into the hepatic vein, and then into your IVC and back to the heart. So going past the liver into your portal veins, at this point, you're expecting that in a normal person, your venous compliance should get rid of that pulsatility. The tissue surrounding your liver, all your liver blood vessels, should also create resistance that gets rid of pulsatility. So in no way should you expect to see that in your portal vein, you should have venous congestion. It should be a flat curve. It should be a continuous monophasic curve, right? They should just be straight. However, in severe congestion, when you look at your portal vein, you will see that instead of seeing this normal continuous waveform on the left, you'll see that it has pulsatility, right? And that's how you know you have severe congestion. The first step is being able to find that vein. And that same idea, that systolic and diastolic, is what you're seeing on a portal vein, which just shows really severe congestion. And the way you measure this is you're looking at the degree of pulsatility. So normally, it should just be like this. However, if you start to see that it starts to go like this, you take the top number, you freeze that image on Doppler, you take the top number, subtract it with the bottom number, and divide it by the top number. That's the percentage of pulsatility, which is also like known as a pulsatility index. And the numbers, remember, is less than 30%, 30 to 50% is grade 1, greater than 50% is grade 2. And when you see pulsatility going the other way, meaning that now instead of blood flow going from the portal vein into the liver, it's going from the portal vein into the intestines, that's grade 3. And so, yeah, that's just basically showing the equation for pulsatility index. The easiest way is to just pause it on our ultrasound machines. You just click, because portal vein exams is a relatively new measurement. It may not be available as a calculator on your ultrasound, but you can just click IVC or you click respiratory variation, and those equations will give you the same number for basically a pulsatility index. And so you can see that in this, so going back to the case that we had, you had both patients. You were concerned in both A and B because in B, you were concerned that there was no respiratory variation. You decided to look at their hepatic vein and then their portal vein. And what you saw was that there was only 20% pulsatility in the patient who had an IVC of 3.4 with a bit of respiratory variation. And in patient B, you saw that they had more than 50% pulsatility in their portal vein. So what the provider decided to do in patient A is that they decided to increase diuresis because they were concerned that this patient had too much venous congestion because their IVC was greater than 2 centimeters. And so they're concerned about venous congestion, but as they diuresed the patient, their creatinine went up. In patient B, who they saw a good amount of venous congestion, they also decided to diurese this patient because they were appropriately concerned about venous congestion. And in this patient, their creatinine started to improve because they got rid of that tamponade of the glomeruli in that intracapsular space by getting rid of that fluid, and the creatinine actually started to improve. And because you decreased the preload in this patient that had severe congestion, their blood pressure also stabilized without the use of vasopressors, without the use of more fluids. And so there is a lot of good evidence of portal vein pulsatility, and it has been shown that in cirrhotic patients, in heart failure patients, in patients post-cardiac surgery, that portal vein pulsatility has a strong correlation with the effect of AKI, meaning that if your portal vein pulsatility is high, indicating severe congestion, that you'll have a higher level of AKIs. So you can apply to heart failure patients, post-cardiac surgery patients, and I think the one that we commonly think about is that you get that patient like this one from the ER who got, their early goal-directed therapy, 30 cc's per kg, and now they're coming in with severe congestion. Why is their AKI continuing to go up? And there's a really nice trial that I'm pretty excited about that should be coming out later this year called the Andromeda VEXUS trial that specifically looks at venous congestion in septic patients. because you think about modern day medicine, there isn't a worse way to try and resuscitate a patient by using a simple equation standardized for every patient. And I'm not calling out the ER. I'm also calling out like every doctor that strictly is practicing early goal-directed therapy, a therapy that was written more than a decade ago, that I think in today's day in medicine should not apply. That not just because a patient is concerned, that you're concerned about sepsis. There's many reasons for why someone should be tachypneic. There's many reasons for why someone should have a high white count. There's many reasons for why someone should be tachycardic. That not everyone you classify as sepsis should be getting 30 cc's per kg, because when they come up to us and we put a probe on them, we see very commonly, more often than not, evidence that these patients are suffering from venous congestion, that their perfusion, their ability to perfuse their liver, to perfuse their kidneys, is impaired because of the amount of fluids they got. And if you are concerned about that, then you can apply the study and kind of confirm that. Keep in mind that in some patients, this might not work. For example, your cirrhotic patient whose nice, pliable liver tissues has become a rock and is causing dramatic increase in resistance. So you'll get that false negative. You won't be able to see that pulsatility, even though that severe congestion is there. Also, in healthy patients, like majority of you, when you would have severe congestion, and you will still see a non-pulsatile color flow, because you are able to move all that fluid forward. So even though you're showing evidence of congestion, you are able to move that fluid forward. And so, we talked about like, and I can send you guys like the flashcards of this. So it's, as you do it over and over, you'll start to remember it. But basically these images, what's grade 1, grade 2, grade 3. And so we talked about the portal vein. Now, finally, when looking at the venous side, you can enter, if you have severe congestion, you can look at the renal veins. I will say that even despite trying to do this exam as much as possible, I'm only able to find the renal vein about, initially 30% of the time, maybe now 40 to 50% of the time. And I only see it in patients where it's severe congestion. So what you do is you take your probe to the kidney, to the right kidney, and you put your Doppler on and you find your color Doppler on and find out where you see flow. Majority of the time, you will only see arterial flow. And remember that arterial flow, when you're pointing the probe, should be coming from the heart, from the aorta into the renal artery and going towards the probe. So Bart, blue away, red towards. So in this case, yes, the red color should be representing an artery. You will see that when you put Doppler, you see where that color is coming from, and you put your Doppler on there. So you click the D button, and then you put your Doppler line on where that color is, and then you'll see an upward reflection. And then you'll see also a downward deflection. That downward deflection, meaning below the line, represents flow that's going away from the probe, and that represents venous flow. Majority of the times, it should be continuous, or you should not see it. Just pausing the venous side for a second, there is a good amount of studies, including done by some of our intensivists, that show what happens when you look at, applying that same equation of your pulsatility index. You look at the artery and you see how high can the artery flow go, and then how low does it go? And you take the max flow minus the minimum flow, divide by the max flow, getting your renal resistive index. When you have a high renal resistive index, that has been linked to AKIs. And so when you're resuscitating a patient, one way to do it is that, you say, okay, maybe I think this patient needs to get fluid off. You diurese this patient. And if you see an improvement in renal resistive index, it means that you are adequately improving flow to the kidneys. If you say you put on norepinephrine and you see that the renal resistive index goes higher, that norepinephrine is causing more damage than good. But you switch to epinephrine and you see that the renal resistive index improves. So you scan them, you come back, you get your number, you put on epinephrine for a while, you come back, you remeasure the renal resistive index, and you see the number improves, and you can say that, yes, in fact, that the epinephrine is better for this patient than the norepinephrine. And the same thing applies to any type of intervention you do, whether it's applying fluids, a certain type of pressor, diuresing a patient. So you go back to the venous system. If you are able to get your renal flows, your venous flows, you should normally see a continuous negative deflection. So below the baseline, you should see a continuous flow. If you start to see that there are little peaks under that negative deflection, that means you're seeing a pulsatility pattern in your renal vein. And that, by definition, indicates severe congestion. Initially, you'll see two patterns, the S and the D. And if you only see one, that's grade 3, meaning you're only seeing your diastolic return because your systolic flow has gone the other way. So this, in summary, kind of summarizes your VEXUS protocol. In the way that they did the studies, which I do think is going to change down the line, is that they only followed through with the hepatic vein, portal vein, and renal vein evaluation in patients who had an IVC diameter greater than 2. So they selected patients who showed signs of congestion. If the IVC diameter is less than 2, it's by definition grade 0. If the IVC is more than 2, then you go ahead and you measure your hepatic vein, your portal vein, and if you are able to, your renal vein, though majority of the times you may already have your indication whether the patient has congestion or not based on your hepatic vein and portal vein. And it's very important, once again, to not stop at just the hepatic vein because of all those other reasons that we mentioned. Maybe, like the majority of our patients in our hospital, may have some evidence of RV dysfunction that may have caused remodeling of the hepatic vein. And so your hepatic vein maybe have a false negative or a false positive. And so make sure you look at that portal vein. And then, if you see that even one of them is that severe level, it meets grade 1. If you see that 2 of them are severe, then it's a grade 3. Sorry, if it's one of them, it's grade 2. If it's severe, then it's grade 3. If any abnormality, meaning any evidence of congestion in the portal vein, hepatic vein, or renal vein, then it's grade 1. So here's just 2 flashcards. I'll send it out on the WhatsApp thread so you guys have it. In terms of how to find these images, I think, you can replace actually doing this at bedside. I do recommend that for your IVC, you look subxiphoid, you find your right atrium first. And then when you find your right atrium, then take your probe and then just fan it down towards the IVC and then get your IVC in a transverse and a short axis. Majority of the times in a young, skinny patient, you will be able to find the hepatic vein from that subxiphoid view. If not, you can always, usually in your more obese patients, go in from a lateral oblique view. So you go to outside of the liver and then go from outside the liver into your IVC and look that way. Your portal vein, majority of the times you will find it on the outside view. The way I would like you guys to remember it is that, I don't know if you guys are able to see, but when you are scanning this way, you find your IVC this way. Majority of the times, if you fan your probe towards the anterior abdomen, you will start to see your portal vein. And so if your IVC is in this view, take your IVC and you see your hepatic vein as well, fan your probe up towards the top of the abdomen, and you'll start to see your portal vein. And other markers of what generally a portal vein should look like from that view is that the portal vein usually has a very thick border to it. It's usually a lot skinnier, and a confirmation could be color Doppler. So if you're looking at it from that view, blood should be going from the intestines into the liver, meaning towards the probe. So the color on the Doppler for the portal vein at baseline should be red. That should be additional confirmation. So once again, we'll practice actually doing VEXUS scans either in person or at a separate POCUS hands-on session in the coming weeks. But that should cover the majority of the didactics portion of this. With that, I'm sure you guys have a lot of questions. What can I answer?
I think it's just going to be a lot of review for us and watching videos and learning how to do it. I don't know if there's any questions in particular we have right now.
I have a question for the hepatic vein for the Doppler. So you don't have to change the angle. You can just put it over the vein and that should be fine.
Did you hear that, Uday?
No, I did not.
So for the hepatic vein, when you do the Doppler on that, do you have to change the angle? Or can you just put it over the hepatic vein and any angle would be okay?
Any angle is fine. So, like when the classic teaching is that when you're doing like Doppler exams, especially for cardiac function, like trying to measure your LVOT, VTI, and things like that, you have to get it in that axis, your straight axis as far as you can. So you want to make sure your probe is adjusted so that your LVOT is in axis with your Doppler, right? This doesn't apply here because what you're measuring here is your velocities relative to each other. You're only really caring about the direction of the velocities. You're not caring about how severe that velocity is. Meaning, I don't care about the absolute value of that velocity. I care about that value relative to each other in that one image and the angle that the velocity is going in. So it really doesn't matter. As long as you're able to figure out what direction it's going in, you're fine. And so whether you're perfectly in line with the whether your Doppler is in line with the flow of the hepatic vein, like even if your hepatic vein is like this and you get your Doppler like this, it's fine. It doesn't have to be like this, and it can be here or it can be here. It doesn't matter.
And is it the same for the pulsatility for the portal vein?
Mm-hmm.
Okay.
Because once again, you're just measuring that in that image. So if you say your portal vein is looking like this, whether you measure it here or here, you want to go for the area where you get the best flow. And whether your Doppler is like this, your Doppler gate's like this or like this, all you're caring about is that in that one space, when I'm getting backwards flow, how much pulsatility am I seeing in that space? And whether you do it in this plane or in this plane, it's not going to make a difference because you're looking at what it is in that one image. You're comparing it to each other and you're not trying to get absolute values.
Okay, thanks.
So yeah, if there's one thing that you guys take away from this patient is be cautious about giving patients fluid. And then when resuscitating, try and assess venous congestion as your first marker. Ask the question of, can this patient tolerate more fluids and should I be diuresing this patient or not? Another common thing that I think, what I've learned from doing this a lot is that, the question that, oh, I don't want to diurese this patient because their blood pressure is low. Well, what you'll find is that as you diurese the patient, even with someone with a low blood pressure, is that you decrease that preload. Their blood pressure actually improves. You improve renal perfusion, meaning you're getting rid of that acidosis. That's also likely causing some level of low blood pressure. You're helping to collect electrolytes that could also be contributing to the low blood pressure. And, in a few hours from now, your hemodynamics stabilize more so than remain low. All right, awesome. So I think next we have